Hi, everybody. Thank you for being here. My name is Dr. Jennifer Surratt. I'm with Emory's Center for the Study of Human Health. And as part of this role, I have been organizing speaker series every year. Last year, we did a series on race, health, and ethnicity. And the topic of this series is relational health, thinking about the ways that isolation and social connectedness impacts our health. We've all been experiencing this in the past 18 months because of the pandemic, obviously. So it's something that's important to us all. We've been talking about it sort of as a public conversation, a lot about how isolation and social connectedness impacts our mental health. And that's a really, really important feature of this. But I also wanted to talk about how this relates to our physical health. And so in that vein, I collected this wonderful group of scholars to come and talk about their work in this area. So I'm going to give a brief introduction of each person, and then they will go, each of them will talk for 15 to 20 minutes, and then we'll have time at the end for some questions. So if you have questions during the presentation, you can put them in the Q&A box or in the chat box, and I will monitor that and get to them. If you have a question for clarification that needs to be spoken or asked in the moment, then I can interrupt and ask that in the moment, but otherwise we will wait until the end for all the questions to be asked. So I really appreciate our panelists' time for being here and for the work that they do. Each one of you does incredible work. Dr. Ellen Eiler is the Director of Religion and Public Health Collaborative and is the Samuel Candler Dobbs Professor of Sociology and Epidemiology. She is a fellow and the current past chair of the Behavioral and Social Sciences section of the Gerontology Society of America. Dr. Eiler studies the influence of attitudes, beliefs, and social connections on health, including the effects of self-ratings on health on mortality and disability, and the impact of religious participation on health and the timing of death among the elderly. Research supported by the National Institute of Aging funding included the first award that supported all of that work. She has served on the editorial boards of some really high-profile journals, including the American Journal of Sociology, the Journal of Gerontology Social Sciences, the Journal of Health and Social Behavior, Sociological Forum, the Slovenian Journal of Aging, and Rutgers University Press. Dr. Eiler is going to be our first speaker. She will be followed by Dr. Heeju Sohn, who is an assistant professor of sociology here at Emory. She received a joint PhD in sociology and demography from the University of Pennsylvania and has completed a postdoctoral fellowship at UCLA's Fielding School of Public Health and the California Center for Population Research. Dr. Sohn's research interests intersects health policy with family demography, social stratification, and health across the life course. Recent projects funded by the National Institutes of Health have focused on the role of health policy and demographic trends in creating unequal safety nets that reinforce social inequalities and inequities. Her research aims to inform effective health and family policy that will alleviate the pervasive disadvantage that persists across generations. And after Dr. Sohn, we will have Dr. Jennifer Mascaro, who holds a PhD in biological anthropology from Emory University. Her doctoral work examined the impact of compassion meditation on social cognition and brain function, and postdoctoral work investigated the biological bases of paternal caregiving behavior. Dr. Mascaro's current research program examines interventions that enhance social connectivity and in doing so impact health. Ongoing projects include longitudinal investigations of compassion and mindfulness meditation training for diverse populations, including Emory healthcare employees, medical and physician assistant students, patients with chronic pain, and veterans with post-traumatic stress disorder. So I appreciate all of you being here, and for those who are joining us as attendees. And I also want to point out that we have the ability to have live transcripts. So if you would like to use that access tool, there is a button at the bottom of your Zoom screen that says the CC. And so you can do live transcript that way. And without further ado, I'm going to mute myself and give it over to Dr. Eiler.
Hi, everybody. I'm very happy to be here with you this afternoon. I got the job of starting us off and thought that a presentation of some of the really antique research in this field would be a nice way to start. I think I've chosen a few different people's work to talk about that I think contributes some key elements to what the research has developed into today. And I'm sure that our other two speakers will give you a more contemporary view. So like I said, it's going to be really antique. Let me share my screen. Can I get a thumbs up from somebody that you're seeing it? Okay, great. All right, great. So yes, so my job is to talk about the history. And so in order to study social ties, you have to be able to count people. And before the 19th century, nobody really counted people. But in Western Europe and in the US, in the early part of the 19th century, people did start counting people. And so the first person I'm going to talk about who was counting people made some pretty interesting discoveries. So this is William Farr. He lived during most of the 19th century. He was a very poor kid who lived in Shropshire, and he was apprenticed to a surgeon. So in those days, surgeons took care of cutting things, and other kinds of physicians gave people medicines. But the surgeon that cut things, he was apprenticed to, and then the surgeon died and left an inheritance to him. So he actually, although he was a very poor kid, got to attend medical school in Switzerland and in France, and then returned to London and set up a practice as a physician. But he was really interested in statistics. And so he began to work on health-related statistics at the General Register Office in London, which was the office that was beginning to take care of the census being the counting of people. And the particular thing he worked on was enumerating causes of death. So the kind of vital statistics that they were collecting were births and deaths and marriages. And so the information that went on the death certificate would include whether someone was married or not, when they were born, and also perhaps their occupation. But whether they were married or not was something that was of great interest to him. So he made so many contributions, and he was recognized for his work. He was the president of the Royal Statistical Society in the mid-19th century, and wrote his most famous work, The Influence of Marriage on the Mortality of the French People, in 1858. So his finding was that people who were married were less likely to have died than people who were never married or who were widowed. And he did this by counting the death certificates and the information on them. He also practiced marriage. So he got married for the first time in 1833 and was widowed fairly shortly thereafter, married again in 1842, and had lots of children. So I think this is a nice way of thinking about the first social tie that got counted and its connection to human health. I wouldn't say he had any theories about it. For that, we have to go to the next contributor. And so sociologists started thinking about why social ties might be a good thing, why they might be protective against different causes of death. And the cause of death that was of concern, was the sociologist we're talking about is Emile Durkheim, who wrote one of his early works was Le Suicide, or Suicide, in 1898. And he also made great use of the data that were being collected by governments, by the French government, by other European countries. He used data from a number of different countries, and was interested in the causes of suicide. He was interested in the particular cause of death, of suicide, and what social factors might be associated with it. And in a way that was somewhat, I guess you could say, paradoxical or intriguing. Why would he choose a cause of death that seemed to be so certainly an indication of isolation, but also of individual choice? And So this particular cause of death, to him, spoke a great deal about the social ties that people had. And so in order to understand it, he felt an urgency about it, because in Western Europe at the time, because they were compiling death certificates, they knew that suicide as a cause of death was increasing. And this was very troubling to many people who connected it with many of the fairly rapid social changes that were taking place in Western Europe, in these industrializing societies, these rapidly urbanizing societies of Western Europe were all experiencing increased rates of suicide. And that was troubling to Durkheim. So his theory was that well, of course, by counting social ties in different ways, not only marriage, but other kinds of social ties, including friends and relatives and membership in religious organizations, membership in voluntary organization, membership in unions. His theory was that people who had more social connections were able, through those social connections, to reduce both alienation and anomie, so the two words that I've got highlighted here on the slide, are both very important axes for understanding the impact that social ties have on people. So his term alienation, another way to think of that is the lack of integration. So people who had few social ties, according to Durkheim, lacked intimacy, they lacked caring, they lacked support, they lacked closeness, they lacked a warm touch, and so were socially isolated and had less of the emotional sustenance that we get from our social ties. And so people with few social ties suffered from this lack of integration. But very importantly, he also said people who lack social ties also lack regulation. And the term for this was anomie, a French word meaning without norms or without rules, the rules being regulation. So Durkheim thought that, that lacking the caring social support of social ties was very important. But the other thing that social ties do is that they control us. They control our behavior. They guide us. They give us feedback about how we're behaving. They provide constraints against our otherwise boundless desires for things. And so I think Durkheim saw kind of rampant individualism of the time as one of the things that was driving people to suicide and causing them to lose social ties. And he felt that the important aspect of guiding or regulating our behavior was a really important aspect of what social ties do. So I think that, you should think about both of these things, not only the friendly part of it, or sometimes I like to say, like there's the carrots of social ties, but there's also the sticks. And those were just as important to protecting people against suicide in Durkheim's language. He tended to think of social ties as being interchangeable. And so religion or occupational groups, community organizations, those were all valid types of social ties. And generally, the more people had of them, the better. Durkheim's theory allows that too much regulation or too much integration could also lead to suicide, but that was not what he was worried about. The suicides of the modern world that were increasing were the suicides of the lack of integration and the lack of regulation, not too much of it. Okay, there we go. Okay. So the first truly modern study, I want to, so we have Durkheim's theory, and then going back to counting things and counting all different kinds of social ties. This early study that I'm about to show you establishes the thing that I really want to impress upon you, which is that there is a dose-response relationship of social ties with mortality. So all along the spectrum, from the fewest social ties to the most, the protectiveness increases. This is a chart from the Alameda County, California study, which was begun in 1965. This paper was published in 1979. It was a real landmark breakthrough paper written by Lisa Berkman and S. Leonard Syme. Lisa Berkman was a young graduate student at the time, and this was her dissertation. I was lucky enough that she was on my dissertation committee when I was in graduate school. So and there were follow-on projects. So I was fortunate enough to be able to be involved in a second generation of Lisa Berkman studies, which was great. So the data here show age and sex specific mortality rates. You might have thought back when I was talking about counting people who were married, you might have said, well, yeah, but people who are married are going to be younger than people who are widowed. And doesn't that sort of invalidate this? Farr wasn't sophisticated enough to do that, but Berkman and Syme do show us the data here broken down by age group. So this is the data for men for mortality follow-up over the 9-year period of 1965 to 1974. And the bars represent all-cause mortality. They are percentages, so they're real simple to read. And the little numbers are even right up at the top of the graph. And very helpfully, they put the number of people who are in each of these bars right below it, so you know exactly how big the samples are. And we have people aged 30 to 49, 50 to 59, 60 to 69, and repeated over here for women. So the purpose of this study was to examine what were emerging as the leading risk factors for mortality in the mid-20th century. Sorry, I need to keep my hand off my mouse. The thinking was that the emerging, the epidemiological transition had changed us to mostly chronic diseases as causes of death. And many of those chronic diseases were lifestyle related. And so smoking and exercising and eating 3 meals a day were all the kinds of behavioral factors that epidemiologists were interested in the mid-20th century and still today. But the Alameda County study was fielded for the purpose of studying those things. Why? So you might say, well, why did they put anything about social ties on this study that was supposed to be about smoking and other risk behaviors? Well, the reason is because they took the World Health Organization's definition of health very seriously. And that definition includes a sense of that the person must have physical, emotional, and social well-being. So they asked people about their social network ties. And I put the list over here. The social network index that Berkman and Syme created included whether the person was married or not, and they doubled that because it was an extra important tie. Whether they had close friends and relatives contact with them, whether they were a member of a religious group, and whether they were a member of a voluntary association. And so people who had more of those social ties had the most connections up here. Those are the blank bars. And those with the fewest connections are the ones with the diagonal hatching. And as you can see, there's a dose-response relationship. So the fewer the connections, the higher the risk of mortality. And that's pretty high. If you look at the men who are in their 60s, over that 9-year period of the men with the fewest social ties, 40% of them died. So that's a lot. Even in mid-20th century, that was a lot for people in their 60s. Women's rates are not as high as men's overall, but you can still see that, except for this one, there's one exception to the overall dose-response relationship. So keeping my eye on the clock here. So this was from 1979. This was a real breakthrough study that established with much more modern statistical methods that social ties were associated with all-cause mortality. That study, the Berkman and Syme study, was updated in 2013 by researchers at Duke University who tried to do exactly the same thing. Using data from the NHANES 3, very big sample, and they had a mortality follow-up from 1993 through 2006. And they tried to create the same exact social network score. So they've got the most isolated with a 1, the not isolated with a 4, or the most connected with a 4. And if you look over here at the survival curves, this is over a 200-month period. It's a long follow-up period. The solid line for the most isolated shows the fewest surviving over the period. And it's, again, a dose-response relationship, so that the people at the top are those who were the least isolated. And when you see survival curves that have big gaps between them over long periods of time, that's a pretty strong association of the different levels of the social network index. The data are not as clear for men. You can see that the least connected or most isolated are clearly different from the other three, but there's some crossovers in these lines. And so those aren't statistically significant in the way that they are for women. And here, if you would rather look at the hazard ratios, the social network score is associated with a hazard ratio of 1.75, meaning that the women who are the most isolated are 75% more likely to have died from any cause, compared with the least isolated, which is the reference group down at the bottom. And it's the most isolated group is also statistically significant for the men, with a 62% higher risk of mortality. So again, you can see the dose response in this updated version of the Berkman and Syme study. So I wanted to hammer on the point of dose response. And the second thing I want to hammer on is the importance of diversity of ties. And so let me raise for you another older study. This is from a group of researchers at the University of Pittsburgh and Carnegie Mellon University. And they were not interested in all-cause mortality. They were interested in colds caused by rhinovirus. So this is an experimental design. But it has, so it's kind of gross when you read the study. Anyway, I put the reference up there if you would like to delve into the details of this study. They were interested in the numbers of ties that people had, but also in the categories of ties that people had. And so they recruited people, they paid them $800 to isolate themselves for a couple of weeks, to admit themselves to, like the laboratory where they were all tested to see what sorts of antibodies they had against the colds. And then after all their baseline measures were made, then they got like rhinovirus shot up their noses to give them a cold. So they were administered cold viruses. And what they were interested in, whether the social ties that people reported prior to the administration of the cold virus were protective against whether they actually got a cold or not. And so here are the types of social relationships. They had 12. You can see there's lots. I just put them down here. And so diversity was one thing. Frequency of contact was another. But I think the big takeaway from this study was really about the diversity. So the spread of people's networks across a community was really important. And so what were the findings? Well, this is the percent of people who got a cold from getting cold virus shoved up their nose. And according to the objective criteria, I hate to tell you what the objective criteria is, but it's like people had to blow their nose and then they had to put the tissues in a bag and seal it up and give it to the researcher. So the objective criteria was weighing the tissues that they blew their nose into. And then they also asked them what kind of symptoms they had. But according to the objective criteria and according to the self-reported criteria and the Jackson criteria, which were based on clinical tests, in all of these cases, people who had the least amount of social network diversity were the most likely to get colds. And here's some more data on it over here, which I don't think we have time for, but that's okay. You got the main point, and it was pretty gross what they did and how they measured it, but you can see it's definitely objective criteria. So I have one more study, and I want to so we've got dose response relationships, we've got diversity, and the last thing I want to point out is the strength of weak ties, because I think all of these things play into the modern research. And the strength of weak ties is the name of a famous article that was published in 1973 by Mark Granovetter, and in which he made the argument that the overlap in people's friendship networks was a really important thing to study. If two people's friendship networks had heavy overlaps, then that would mean that they had relatively few weak ties because they were all very connected with each other. So there are some little graphs here. The weak ties are the ties, for example, right here, where A to B is a weak tie. So person A and person B know each other. But person B doesn't know any of these people that person A knows. And person A doesn't know any of these people that person B knows. So that's a really valuable tie, because if it were broken, there would be no contact at all between these people and these people. And he makes a really wonderful argument about the importance of the sort of branching networks that people have in communities. And I was going to give an example of religious congregations, because they are full of weak ties where people are easily able to introduce people to other people. And so there's a great strength in weak ties. I love the title of that story. And I don't want to take up any more time, so I'm going to just, 2 final thoughts. None of these studies included the quality of the relationships. They're just about counting them. And you might think that that's a problem with studies, and certainly it is something that people have raised about that issue. My opinion about this is that in general, like, no relationship is all good or all bad. And basically, the more of them you have, the better off you are, because definitely people are aggravating sometimes. But, but you're better off with more relationships, and also more diverse relationships. And the second point is about agency. We choose the people who are in our networks, and we keep them there by cultivating those ties. The size of our networks and the composition of our networks, especially friendship ties, are very much up to us. And if people don't get in touch, if people just, ignore you, or you ignore them, that will diminish the size of a social network. It takes work to maintain a social network. And so the intentionality I really want to bring to this, like, we have to think about our social networks as living things that we need to protect and cultivate and, put some effort into. So keep in touch. You'll be healthier for it.
That was wonderful. What a great
I will
scoping
stop
overview.
sharing.
I really appreciate that. Yeah, really, what a great way to set us up for Dr. Sohn's work. So Dr. Sohn, whenever you are ready.
Yeah. Okay. Oh, my notes just disappeared. Let me just pull that up. Okay. All right. Is this good? Can everybody see my slides? And only my slides, right? Okay. All right. So hello, everybody. Thank you for inviting me to speak on this panel. And Dr. Idler's presentation really laid out how social connection and support can impact people's physical health. So in my section, I'm going to flip the relationship and ask you to think about how someone's health can impact the social support system of others. So what I'm going to do, I'm going to actually focus on a recent empirical project that I wrote about how racial inequities in health create disparate kin support systems between white and Black families in the United States. And as I go through the data and the results, I want you to think about how large and persistent racial health inequalities across the decades can create unequal kin support networks, and what the implications would be for people, especially children and the elderly, who very much rely on their family networks. So this was a headline in the New York Times: a ripple effect of loss, US COVID death approach 500,000. So this article was published earlier this year in February. And as we know, since then, the country has lost another 160,000 or so to the coronavirus. And the magnitude of these numbers make it easy to overlook the fact that each death affects a kin network, and that each dot in this illustration leaves behind a network of parents, siblings, spouses, children, aunts and uncles, and nieces and nephews. And emerging studies consistently show large racial and ethnic disparities in COVID-19 deaths, stemming from existing inequalities in underlying health conditions, access to healthcare, and socioeconomic resources. And African American or Black Americans experience disproportionately high COVID mortality. And what that means is for those families who are left behind is that they're more likely to feel the impact of the pandemic long after the crisis is over. So the health gap between white and Black Americans did not appear suddenly with the COVID pandemic. So this graph shows the gap in life expectancy between Latinx, non-Hispanic white, and non-Hispanic Black populations in the US. So life expectancy is the expected number of years that someone in a particular group would live. We can think of it as the average lifespan. The higher the line that it is on the graph, the longer the life expectancy, and often more years in good health. So this graph shows the difference between the gray line, which represents white Americans, and the orange line, which represents Black Americans, has actually narrowed since the 1980s up until the start of the pandemic. The graph, it's a solid line and it becomes a dotted line, and it's because it's kind of preliminary data. So the trends in life expectancy, which measures lifespan, is consistent with the patterns in the onset of chronic disease and disability. Black Americans have shorter healthy life expectancies than white Americans. They also report earlier onset of morbidity and steeper health declines in middle age compared to their white counterparts. And these trends, they've continued across generations. So the question is, what happens to the family network when disadvantage and healthy life expectancies accumulate in multiple generations? When that disparity exists among grandparents, and then it exists again among parents, and then the children. So before I directly answer that question, let's consider the implications of longer healthy life expectancy can mean for overall social and racial inequality. So the kin network, you can think of it as an upstream source of inequality. Unequal rates of mortality and morbidity along with differences in the timing of childbearing create kin networks that differ in their abilities to pool, share, and distribute social and economic resources. So a couple of slides ago, I put up a headline about a Georgia teen who lost both his parents to COVID-19. So his parents' early death means that he will go through young adulthood, a time when he might be finishing his schooling, starting his career, perhaps buying a home, without the support from or the interaction with his parents. And if he becomes a parent himself, his children will never meet their paternal grandparents. So social scientists have examined the downstream social mechanisms of how families reproduce advantage and disadvantage. Children benefit from their parents' material resources and human capital, even after they become adults. They receive instrumental financial and emotional help from their parents, even when they go off and establish their own households. And researchers have also studied the influence of family resources and support on grandchildren. So the degree to which cross-generational repetition of social status leads to enduring racial inequality and socioeconomic stratifications depends critically on how multiple generations are connected to each other. But because the way that much of the data and the surveys are collected in the US, it can be really difficult to map out the intergenerational family structure, especially if they're living in different places. So in this recent project, what I did was I took advantage of this unique data set, the panel study of income dynamics, to examine the health and presence of 3 generations. So the PSID, that's kind of like the acronym for the data set as it is known, is a longitudinal data set, which means that it followed an original cohort of 5,000 households from 1968. So the survey went back and interviewed the same members every year and then again every 2 years. And they also followed their descendants. which means that they have multiple generations in this data set, and it's still ongoing. It's a fantastic data set to study social relationships among extended kin networks. One big limitation of this data set, however, is that it does not incorporate families and people who immigrated to the United States after 1968. So what that means is that it is very underrepresented in Latino Americans and Asian Americans. So in this study, I had to focus on the differences between the Black-white populations. So the survey asked respondents, so the people in the middle of the graph, I call them Gen 2 or the second generation, about their parents and whether they were alive, and if they were, what their health was. Are your parents in good health or are they in poor health? So the parents, the mothers and fathers of the respondents would be called Gen 1, Generation 1. The survey also collected data on whether the respondent had children living with them in their households. So those would be the third generation, Gen 3. So I combined the information on the three generations to create a simulation of what someone's kin network would be based on their race and gender. So I simulated the time from when a person would be in their prime working and childbearing ages, age 25 to 65. And I created 4 simulations, 2 for women and 2 for men. And by comparing the outcomes of these models, I calculated the number of years that the respondents would be healthy themselves and who also had healthy parents, both of them who are alive and healthy. So that would create a 2-generational kin network and if everyone is healthy, we call them fully healthy kin networks. And then I calculated how many of those years would coincide with the presence of the youngest generation. So how many years would those children would have a healthy mother or father who also had healthy parents? So I am going to spoil the surprise finding. And it's actually not that big of a surprise because it's not that surprising that the structure and the health of kin networks differ between white and Black families. Black adults are more likely to be in poor health themselves, and their parents are also more likely to have poor health or to die sooner. This results in the children of these families to grow up in kin networks in which time and resources needs to be spread out to manage living with a disability or a chronic condition, dealing with healthcare costs, and not being able to work due to poor health. Next question is, how much? What is the difference? How big is that difference? So I'm going to show you the difference in the number of years that white and Black adults have with a fully healthy kin network as they complete their education, work in their careers, basically their prime adulthood between the age of 25 and 65. So first, there is a racial and gender inequity in simply the number of years that adults would live. And remember that I'm simulating the 40 years in prime adulthood. So any number below 40 is due to deaths that occur before someone turns 40. So basically, first, women have more survival years than men. There are also very large differences among men, between race groups, especially among men. So non-Hispanic white women are expected to live 38.7 years out of the 40 compared to 38 years for Black women. And that's a difference of 0.7 years, which is about 8.5 months. White men are expected to live a little shorter, 37.8 years out of the 40, which is actually more than a full year longer than Black men. Now, on top of this, now I'm going to add in the number of years that they live healthy. And the race inequity gets really bad. So white women have 5.3 more years in good health than Black women. And remember from the previous slide that white women on average lived only about 8.5 years longer. So what this table shows is that they spend a significantly larger percentage of their lives in good health than Black women. The race gap between men is similarly large. White men have about 4.6 more years in good health compared to Black men. And I want to pause here and I want to let these numbers sink in because we're talking about a 5-year difference in a 40-year period in someone's life. So one group spends 5 more years in good health, not having to worry about spending money on doctors. They have 5 more years feeling like that that their health is not limiting their careers, and 5 more years not worrying about whether their health is going to affect their capacity as parents. So the last set of numbers I want to share with you combines the health of adult respondents with the health of their parents. So now we're talking about 2 generations simultaneously. So non-Hispanic white women and men spend about 30% of their prime adulthood in good health, with 2 parents who are also both in good health. And that would be around 11 years in their adulthood before one of the 3 people falls ill or die. On the other hand, non-Hispanic Black women and men spend significantly fewer years in good health with healthy parents. Black women have about 5.6 years, which is about 15% of their prime adulthood. That's half compared to white women. And Black men have about 6.9 years. So the day-to-day differences in the experience are simply more than these numbers. White families have more time, more years in their lives to ask for parents for financial and instrumental help, whether it be just asking if they can live with them for a bit between jobs as they figure things out, or asking perhaps some help on a down payment on a house, or even just asking whether they can babysit the kids for a weekend. And poor health has been shown to decrease the capacity to help, as medical costs, energy, and mobility, they all start taking a toll. So let's put this together and think about what this means for the children who grew up in these very disparate kin networks. The impact of unequal timing of morbidity and mortality in the 2 generations, the parents and their adult children, can stretch into the next. And on average, Black children have 2 fewer years in a fully healthy kin network. And the race gap is smaller here because than the differences that I showed you in the previous slide, because of the difference in the average age at childbirth for white women and Black women. So because Black women give birth earlier, their parents and grandparents tend to be younger. But despite that, there's a disadvantage among Black children in living in a fully healthy kin network. And children generally benefit from grandparents' involvement and support. For example, during periods of economic and marital crises, some adults doubled up to live with their parents. And the grandchildren who came along were protected for the most part from the negative consequences of material hardship. But poor health among grandparents, however, is likely to redirect the flow of resources away from the grandchildren towards the grandparents. So adults may relocate, they may move closer to their parents to deal with parents' ill health and disabilities. And the grandchildren face disadvantages compared to their peers who have healthy grandparents. And the caretaking burden on the adults who must support their parents and their young children at the same time is substantial. The stress on adults induced by the addition of unpaid care is linked to heightened risk of poor child health. So the results I've shared with you so far focused on how unequal health impacts the younger generations, and that's where my research focuses on the most. But other researchers have examined how racial inequities and healthy life expectancies what they can mean for the older generation. So Margolis and Wright, so I went to school with Rachel Margolis, who's the first author in this paper. She also ran simulations to estimate the number of years a person would be as a healthy grandparent. And their findings reflect my own. White men and women spend more years as a healthy grandparent than their Black counterparts. And this is even accounting for the fact that they become grandparents later in life. And that's due to differences in age and childbearing. So these researchers were able to create simulations for the Latino population as well. So Hispanic men and women became grandparents sooner in life than the other 2 groups, but had significantly fewer years as healthy grandparents because of early onset of poor health. So if mortality is high in a kin network, there might be instances where people are left without any surviving kin. And I think this kind of ties into the topic of the next panel, is that this study simulates this extreme case where a person does not have any surviving kin. And based on trends of marriage, childbearing, and mortality, the researchers here, they projected that by 2060, about 15% of Black women and about 12% of Black men in the United States would be living without any kin. And I think the kin they defined as parents, children, and siblings, and direct descendants, so grandchildren. The solid lines are those for white men and women in this graph. And according to these author simulations, the racial gap is expected to grow. The difference between the solid line and the dotted line are getting bigger. And I want to point out that this study was published in 2017, before the COVID pandemic happened. And I expect that if they were to update their simulations using data from last year, the gap will be even larger. So I'm going to end on this slide to reiterate the point that the relationship between health and social connectedness is not a unilateral one. And physical health affects social support system, and it can reinforce existing inequities in health. So thank you for the attention, and I look forward to the questions.
Thank you so much. That was really interesting, thinking about our kin networks and the cumulative intergenerational impacts. It's really fascinating. And Dr. Mascaro, over to you whenever you're ready.
Wonderful. Thank you so much. It's really a great pleasure to be here with, I've learned so much from both of you, Dr. Sohn and Dr. Eidler. I always learn so much from you, Dr. Eidler. It's my pleasure to sort of go last here and in some sense tie our discussion up, I hope. But what I'll also be doing is sort of diving down and bringing the discussion to a different level of analysis. So I'm a biological anthropologist, and my interests are in how social connection affect the brain and body. And so we've just seen really profoundly how these bidirectional pathways between social connection and health. So Dr. Eidler showed us the foundational research tying social connection with morbidity and mortality in those early studies that sort of kicked off this line of research. And Dr. Sohn just showed us the amazingly profound data linking health inequities to the downstream effects on kinship ties and social connection. And so for the last 20 minutes or so, what I'd like to do is look briefly, because there's not a lot of time, but I want to share with you an overview of some of the physiological systems that underlie these relationships. And I'm going to show you another bidirectional pathway. In this case, I think this is a scenario in which we gain a lot of understanding by looking at the physiological mechanisms that tie isolation to the health risks, or the opposite, by which rich and diverse social connections can confer health benefits and protective effects. And so in this case, what I want to show you is the evidence for bidirectional pathways between the brain and immune system. So this is a killer T cell shown here in green and red, and we've heard a lot about those T cells lately. So I'm going to begin by talking about the influence of the brain and mental states on our immune function. And then I'll end by talking about the other end of this bidirectional pathway, the way our immune system actually affects the way our brain functions and the way we perceive the world. So to begin with, the first side of this bidirectional relationship, I'm actually going to also begin with some of the antique research. This is a study that came out in 1981. I was 3 years old. This is a study that was done in rats, where the researchers had 4 groups of rats that were randomly assigned to 4 different conditions. So one group got a home cage. They got to hang out in their familiar stomping grounds, and they, didn't get any sort of stimulus. A second group was put into an unfamiliar cage and didn't get any stimulus. And then the other groups got a series of low and high shocks. And what we're looking at here in the graph is a look at lymphocyte production throughout, over time, while the rats were getting these conditions. And this is psychoneuroimmunologists who study the relationship between the brain and the immune system kind of sometimes refer to this as sort of the old story. The first way that scientists began thinking about the way that stress interacts with the immune system. And the idea here was that intense and prolonged tail shock, and this was like for 19 hours, these poor rats, suppressed the lymphocyte or T cell response. In a subsequent study, this was in 1991, and I see Dr. Eidler and I are on the same page here because this is that same group, Cohen, who seems to love to measure snotty Kleenex. This was an earlier study that their group did, but very similar design, where they had people come in and they first had them take a self-report survey of their levels of psychosocial stress. And then they had them sniff one of 4 different rhinoviruses, and then the control group, the lucky group that got the saline spray. And then they split the group. They did a median split and split the group into high and low stress, and they tracked people over time to see the percentage of people who showed up with a cold. And this is something that we kind of all know based on our own lives, phenomenologically, right? When we are experiencing elevated stress, we're more likely to develop a cold. So again, this idea that psychosocial stress impacts the immune system in a way that actually makes us more vulnerable to disease. And so that was this old story about the way that stress related to the immune function. Now, of course, though, we know that the immune system is incredibly complex. And these first scientists with this old story were really focusing on the acquired immune system, or the adaptive immune system, again, that we're hearing a lot about right now as we think about B and T cells and sort of the memory that they hold to, with vaccines in particular, but also in the case of exposure to antigens. And so these were the systems that these early scientists were studying when they noticed that T cell responses were decreased in these rats who got lots of shocks, and that seemed to, sort of compromised immune function seemed to be linked to increased risk for viral load and so on. But of course, that's not the only part of the immune system, and we have this innate immune system that is sort of the early, more physically sort of phagocytotic response to antigens. And this is that system that has been shaped by evolution to respond really quickly to tissue damage in particular. And so what scientists began to notice in the early 90s in particular was that this system of innate pro-inflammatory responses that are mediated by cytokines like interleukins 1 and 6, this system actually seems to be elevated in conditions of stress. And so with this recognition comes what psychoneuroimmunologists sometimes refer to as the news story. And this is the observation that often in states of stress, there are elevated levels of circulating pro-inflammatory molecules. This observation came alongside another really important observation, which was that quite often when people were experiencing depression and depressive symptoms actually overlap tremendously with the symptoms that we experience when we're sick. So anhedonia, changes in sleep, changes in our energy level, cognitive changes, things that we experience when we have the flu or when we have a virus are quite similar to many of the symptoms that occur in clinical depression. And so these observations led to this kind of new story whereby this system of pro-inflammatory cytokines that gets activated with local tissue damage also becomes active in states of psychosocial stress. And so this new story is that there are these pro-inflammatory molecules that circulate not just locally with tissue damage, but they actually circulate around our bodies and even enter the brain through these sort of leaky blood-brain pathways and affect the way our brain functions. And so we can start to think about this as a system that now is not just responding to the local tissue damage that evolution shaped to respond to, it's actually responding to the perception of danger, of threat, of stress. And so I think this is a really important turn where we start to think about and recognize that exposure to stress and the perception of stress, the perception of our world as threatening or safe actually influences the way these circulating pro-inflammatory molecules are influencing our brain and body. And so the important idea here is now we're talking about perception, we're talking about interpretation, we're talking about a subjective sense of the world. So we can start to think about threat versus safety. What are the things in our environment that convey threat, a feeling that we are under imminent danger or threat, versus the things in our environment that convey safety? And there's decades of research on this. I'm just going to sort of aggregate all of it into a one throwaway slide. When I think about the research on what conveys threat in the context of stress, the person that I think about who's done a lot of this research is Robert Sapolsky, the famous biologist who did decades of research with non-human primates. And the things that his research point to are lack of predictability, lack of control over our world, lack of outlets, the way we interpret stressors as a stress rather than a challenge, lack of social support. And he's done decades of research on this. In contrast, things that convey a sense of safety, I really like a series that has been released every year for the last several years, the World Happiness Report, that points to aspects of that convey safety, like social capital, values, meaning, spirituality, and spiritual values, mental health, physical health, family. Aspects in our world that seem to convey a sense of safety and can then influence the immune system in that way. And so let's think about threat versus safety in another way too. So this is the data that, this is a meta-analysis that came out a couple of years ago. A meta-analysis is a special type of scientific study where you sort of accumulate all of the research that has looked at one specific topic. And this meta-analysis looks at the relationship between acute psychosocial stress on the one hand, and circulating inflammatory markers after the stressor. So here we are looking at an aggregate of many studies that probably is an aggregate of hundreds and hundreds and hundreds of people. And we're looking at the interleukin-6. This is a cytokine. It's sort of a messenger in that pro-inflammatory pathway that sort of says, hey, we need some inflammation here. Let's wallop the body with inflammation because we are in danger. So this is the interleukin-6 response to a psychosocial stressor over time. So you can see 0 to 10 minutes is immediately after the task, the stressor starts, and it stretches out to 2 hours later. And I want to point out a couple of things that I think are really important about data like this. So the first thing is the kinetics of this. In other words, the time span. So you can see that the interleukin-6 response is pretty slow. It's really peaking an hour and a half after the experience of that stressor. But importantly, in general, it starts to drop after that. But in some people, it doesn't drop. So this sort of ideal curve where you respond to the stress and then over time, the circulating cytokines dissipate doesn't happen in everyone. Sometimes those cytokines continue to be elevated for a long time after. The other thing to notice here is the variability. So that's always the case, where things become interesting and important. There's a lot of variability in the magnitude of the response that people have to a psychosocial stressor, as well as a lot of variability in the kinetics. So again, some people drop, after they have this sort of optimal peak to respond to the stressor, whereas some people's cytokine continues to be elevated. And then the last thing is that this is inherently social. And the reason I say that is because all of these data come from a specific psychosocial stress task that has come to be the kind of the gold standard stress test called the Trier social stress test. And I'm going to spend just a second describing this. It's kind of the gold standard laboratory stress test because it is the main task that has been shown to reliably evoke this inflammatory response. And here's why. When someone comes in to do a Trier social stress test, this person who's to us is a study participant. They come into the lab and they're told, okay, what we want you to do is we're going to have you give a 5-minute speech to a panel of behavioral experts. The behavioral experts come in with their white coats, and the participant is told they're going to evaluate your performance on this 5-minute task. Before you start it, your speech, what we want you to do is sit all by yourself for 10 minutes and prepare your speech. And then the behavioral experts are going to come in. And so this person here then gives his or her 5-minute speech. Maybe it's about their dream job. The panel behavioral experts are actually members of the research team, and they give no validating social cues. So if the person makes a joke, nobody laughs, no smiles, no kindness. And then this study participant is told, when you're done with your 5-minute speech, there's going to be a surprise task, but we'll tell you about it then. So they finish their talk. Maybe they've only gone for 4 minutes, and the panel says, okay, you have 1 more minute, please keep going. And they go on for 5 excruciating minutes. And then the participant is told, okay, here is your surprise task. We want you to count backwards by 13 from 2,167. Go. And they have to sit there and do this mental subtraction. And every time they mess up, the panel says, nope, sorry, you made a mistake, start over. And it goes on for 5 minutes. So you can imagine why this reliably evokes an inflammatory response. And the reason is because it taps into those signals of threat that Robert Sapolsky told us about. There's the unpredictability, there's the lack of control, and really importantly, there's the kind of social evaluative aspect and the lack of social connection and social support. And so when people go through this TSST, there are wide variations in terms of their inflammatory response. Even though everyone tends to have a response, the magnitude and the kinetics of it vary. Well, we did a study using this Trier social stress test at Emory with Emory undergraduates who went through either a compassion meditation training or a health control group. This was a PE class before human health came along. And so half of the first year undergraduates were assigned to a health discussion group, and half were assigned to go through a 6-week compassion meditation training. And then they all went through that Trier social stress test. And what we're looking at here is the interleukin-6 response, an hour and a half at that peak time after the stressor. And what we found in this study was that the group of undergraduates who went through the health control, they had a pretty whopper response. And at first we were pretty bummed because there wasn't really a difference in the meditation group. But what we found was that when we split the meditation group into those who actually practiced, went home and did their homework and practiced meditation versus those who didn't, you can see that the group who practiced compassion meditation had a buffered response. So again, this idea that we can change the way we perceive the world as more or less threatening, and this impacts our inflammatory response. So I've just shown you this sort of part of the bidirectional pathway. I'm going to spend the last couple minutes, if I have time, talking about this other direction, and that is the way that our immune system in turn actually affects the way our brain functions. So in particular, there is a lot of research on this point, at this point on this relationship. And part of the reason is because it tends to be pretty easy to study. I'll share with you how some of this research gets done, but to sort of aggregate the last couple of decades of research, what researchers have found is that inflammatory cytokines and circulating levels of inflammation actually affect our reactivity, especially to social stressors and to social stimuli. It alters our reward processing. It alters our cognitive control. So Dr. Eidler was talking about Emile Durkheim's notion of enemy, that regulation aspect. Well, here's at a physiological level how inflammation can actually affect some of those aspects of sort of cognitive regulation. It also impacts somatic syndrome. So the sort of general disorder that's diagnosed when someone has physical symptoms like pain or shortness of breath in response to high levels of stress. It also affects things like anhedonia and social withdrawal. And so I'm going to share with you just some of the earlier studies in this domain, but two of my favorites. So this first one was done by some researchers at Emory back in the early aughts. Lucille Capuron and others were sort of taking advantage of a situation that is unfortunately quite common. One of the chemotherapeutic agents that is given in the context of cancer is called interferon alpha. And it's a chemotherapeutic agent that, it induces a whopper inflammatory effect. And so this line of research, one of the ways that it has come to understand how inflammation affects the brain and the way the brain works is by looking at patients when they receive interferon alpha. And so what these researchers did was they put people into the fMRI scanner who had either received interferon alpha or controls who had not yet received it. And they had them do a attention demanding cognitive task. This is an attention demanding task that results in a lot of errors because it's really difficult. You have to maintain your attention the whole time. And when you make errors, you notice, you're given feedback. So you see when you've made an error. And in particular, they were looking at a part of the brain called the anterior cingulate cortex. You can see it. So this top image is sort of a slice down the midpoint of the brain, and the anterior cingulate cortex sort of sits right in the middle part of the midbrain. The anterior cingulate cortex plays a really important role in error processing, but really importantly, it is a region of the brain that is not just responding to the perception of errors, but it's also, it activates the autonomic nervous system. So the idea here is that this is an important node in the brain where you make a mistake and you activate your sympathetic arousal and your sympathetic nervous system in response to it. And so what you can see is that the patients who got interferon alpha actually had a greater response in this area of the brain when they made mistakes in the task. Here's a second study that came out a little bit later from Naomi Eisenberger's lab, one of my very famous favorite neuroscientists. What their lab did was they administered, this is with healthy adults, they administered an acute dose of an endotoxin. So you can think about whether you would sign up for a study like this. So half of the participants got snorted an endotoxin in a nasal spray and half a placebo. And then they went into the fMRI scanner and they were shown images that were threatening and non-threatening, but really importantly, social and non-social in nature. In other words, they saw threatening social and non-threatening social, threatening non-social, and non-threatening non-social. And so what you can see is that those participants on the left side who got the endotoxin and had this whopper inflammatory response to this pathogen had a much greater response in a part of the brain called the amygdala that we all have heard of because it's of its role in responding to threat in large part. But really particularly, this was in response to one type of threat, and that was social in nature. And then after people got out of the scanner, the researchers asked them to rate how disconnected they felt socially, and their amygdala response during that task was correlated with their self-reported feelings of disconnection. In other words, this sort of whopper inducement of, if that's a word, of the inflammatory response led people to interpret social information as more threatening, and then that elevated response was related to their perceptions of social disconnection. And so the idea here is that in some sense, kind of a harmful feedback loop. So stress and feelings of threat, especially that which is social in nature, feeling isolated, feeling shunned, feeling ashamed, feeling like you're being evaluated negatively, ramps up the pro-inflammatory activity that we know from a whole wealth of studies is connected to long-term harm and chronic disease. But then on the other hand, the circulating inflammation levels actually change the way we perceive our world. They make us feel like our world is more threatening, make us feel less reward from other people and from engaging with others, and make us often feel somatic symptoms like pain and shortness of breath and those sorts of things. So there is this kind of harmful feedback loop. But similar to Dr. Eidler, I'm going to try to end on an optimistic note, which is sort of the flip side of this harmful loop, right? So if we actively shape our world in a way that makes us feel more connected via our behaviors, our thoughts, our emotions, our beliefs, the way we cultivate our social connections, we can then shape our immune function. And the idea with this bidirectional pathway is that if we shape our immune function in optimal ways, it can further affect the way we perceive our world. So similar to Dr. Eidler, the call is to intentional cultivation of social connection through all of the things that we know help us have these rich, diverse, very meaningful connections with a wide variety of people in our social world. And so with that, I'll leave I'll leave the slides, and I think that we will go ahead and do some discussion and question and answer.
That was wonderful. I feel like I understand myself a whole lot more after these 3 talks.
Research is just research, right?
Exactly. Research. So those who are attending, if you have any questions, go ahead and put them in the chat box or in the Q&A box. Either is fine with me. I, of course, have a long list. And so the one I want to start with the question I want to start with first is, what is the relationship? I've been thinking about how to phrase this properly. There's something protective, right, about social connectedness and something harmful about isolation. How do you tease those 2 impacts out, right? So do researchers like yourself look at that? Are we able to say this is a protective effect of social connection and versus this other impact, which is this is a risk effect of isolation? And I'm just going to throw that out to all of you. So whoever would like to kind of tackle it first, just feel free. Yes, thank you, Dr. Sohn.
Yeah, I can start. Actually, that was the very question that I was thinking about as I'm embarking on my research agenda, because at least the project that I presented, it starts off with the assumption that having a kin network is positive, but that's not necessarily the case. So empirically, some of the ways that people have tried to tease out the difference in a survey perspective is to explicitly ask, in addition to, do you live close with your close family members or your friends? And then you start going through them and asking questions about the quality of the relationship. So do you feel that you can rely on them, or do you feel that they ask you too much of you? And by going through a kind of a battery of questions, people can quantify both the number of close connections, but also whether it can be a sort of a positive versus negative. But that also comes with limitations, because a person is not entirely negative or positive. And by asking the survey questions that way, you're essentially asking them to categorize people into buckets. And that is very probably in reality fluid, depending on the time of day, perhaps the question was asked, or what their last interaction was like. So that's at least from a survey perspective.
Thank you.
Well, I guess I would go back to the idea of the dose response relationship, because those studies weren't classifying people into two groups. They had a scale, and the mortality was sensitive to more and fewer social ties. Yeah, I mean, I think I sort of said something at the end about how those studies are often criticized because the quality of relationships is not included. Dr. Sohn says it's hard to measure that. It is, but is anybody's relationship with anybody all positive or all negative, or any one day it changes, right? So I think when people were being asked to count those ties up, they were simply, people they knew, people that they, their friends and relatives. They might have all been aggravating all the time, but they still put them down, and they were still better off because they had them. So in some ways, the simple approach to this actually had, because it is connected with all-cause mortality, it has a rather objective sort of gold standard of measurement for health. And so I tend to not worry about too much about the quality of relationships, but I take your point about measuring isolation or measuring connectedness, because I think people are taking different approaches to this, and certainly during the period of COVID, people have been worried about the radical end of really very total isolation for many elderly people who go for several days without speaking to another human being, even maybe on the phone. They're really very isolated. And so there's been a focus, I would say, on isolation. And you might have noticed, like I had the Berkman study, and they had social network index, and it's, from low to high connectedness. And then the people who replicated it at Duke were interested in measuring social isolation, and less social isolation was more connectedness, but they still anchored it with the concept of isolation. So in some ways, it's a researcher's choice, I think, which way to direct it. But, as the social determinants of health perspective tells us, there's a gradient in health. There's a social gradient. It cuts all the way across, and more unequal societies have this, there's this, the level of, inequality in a society is connected with health in very profound ways, and it cuts all the way through. It's not just a matter of the extremes. So I think it's somewhat researcher's choice, but also a social problem in this time period where we are, where isolation is a real thing.
Yeah, I think that's really true. And I think my read of the most recent really big meta-analyses is that the idea is that you can actually disambiguate the effects and find effects of both. That is, that there are clearly established effects of isolation, of a lack of kinship and social network ties on a day-to-day basis. And then there are effects of the subjective sense of loneliness, and they're measured in different ways, but they both seem to exert really harmful effects on people in measurable ways. The other thing that I think is really interesting with some recent research is the pointing or highlighting how variable people's response to isolation is. So there was a study a couple years ago where they had people sit by themselves in a room for like 30 minutes with nothing, no phone, nothing to read. And they gave people the option to self-administer electric shocks. So that was sort of their only way to distract from themselves. And 40% of people chose to shock themselves rather than to be isolated. So there is, I think, even with isolation, there's variability in how, distressing it can be to people.
Yeah, as an introvert, I'm like, I love being by myself, but as somebody who like fidgets a lot, I'm like, and I would definitely give myself electric shocks. All right, we have a question from the audience. How do contemporary public health interventions, if they exist, seek to reconcile growing racial inequities in health, kin networks, and social outcomes? Do they seek to primarily address the quality or quantity of social ties?
I think I can start with that again. So the question is asking, how do contemporary public health interventions seek to reduce the racial inequities in health via kin ties. So because I think a lot of the way that research have evolved over time, focusing on marriage and the way that data was collected, interventions have focused on marriages and partnerships. And they have both tried to deal with the quality of the marriage and also whether someone remains or chooses to marry. One of my colleagues at UCLA, where I did my postdoc, what his lab would do was invite couples to come and to talk about, or at least probe them to talk about conflicts in their marriages. And his lab would come up with effective interventions of very different kinds, from counseling to activities. And at the end of the day, what he found out, the most effective thing that reduced conflicts between couples was money. That paying people, giving people more money, reduced the number of conflict, especially among couples within a certain income range. So that kind of highlights this circle of how social deprivation and material deprivation feeds into both the quality and thus the quantity of important kin ties, which, as from this panel, we know that feeds back into health. Yeah.
That reminds me of what Dr. Mascaro was talking about with threat and safety. Do either of you have any, Dr. Either?
Yeah, I could jump in here. So some other of the research that I do is on religion and the belonging to religious organizations. And I just mentioned that briefly as a source of weak ties, because even a relatively small congregation will have a range of people where you know some people very well and other people you barely know, but you recognize because you've seen them before, but you don't know them very well. But there's undoubtedly, there are pathways through which you could meet that person if you wanted to. And the example that's often given for the strength of weak ties, which is, I am going to get back to the question, is that, your closest ties are not the people who are going to help you get a job. Because if they had a job, they would have already given you a job and you wouldn't be jobless. But it is the weak ties who are likely to know of an opportunity that you don't know about because you have that one weak tie to that entire other network that could easily bring you some opportunity. So when we talk about the sort of substitutability or the interchangeability of network ties, I think that's a really important dimension of it that goes along with the idea of agency and intentionality and maintaining ties. There are, not everybody's born into a big family. Not everybody is blessed with lots of brothers and sisters. And that leads on to subsequent generations with fewer, as Dr. Sohn's research shows. But there are groups like community organizations and religious groups and volunteer organizations that people can join intentionally and therefore create networks for themselves by volunteering their time and doing something good for their community. So from an elderly person's perspective, the idea of social isolation in old age, I often think, a lot of social ties are diminishing for older people, and marriage especially is one partner will precede the other in death. But so you need to not turn to the potential social ties that are given by family, but those that can be generated in a voluntary way. And religious groups are always very happy to see people. So because they're all losing members. So there are many groups that in communities, not only religious groups, but others that will welcome the joining of new members. And you can do something about it. And I think that especially Granovetter's article about weak ties draws very much on the advantages for economic well-being and the reduction of inequity through the generation of more network ties. So we should be looking to those voluntary sectors of network ties as a way of answering that question.
Any thoughts, Dr. Mascaro?
Oh, I think we have the two public health experts. I do more individual level interventions, so I don't think I can add anything.
Well, you might have, I think that you'll have some insight into this next question, which kind of overlap with a question that I really, my work is largely with autism and disabilities like that. And we do see people who just aren't interested in a lot of social ties. And so this question that from Quinn in the audience says, how does social anxiety play a role in the perception of social ties and the manifestation of protective health effects? And so similarly, I wanted to ask, what about people who don't like social ties?
Yeah, so I think to your question, I think it sort of harkens back to our earlier discussion about the difference between the subjective sense and the actual isolation or quantification of social ties. And so, someone who is not bothered by not having a diverse and rich social network is probably not going to have as much harm from it as someone who, is really intensely bothered and feels that the world is just out to get them and that they're ashamed of it. So not to say that there wouldn't be any harmful effects, but it does seem like, there is a big part of this that is about the distress and the, how the subjective sense of loneliness. The other question, though, is about, the wide diversity of the way we all experience our social world, and the way some people, myself included, the sort of social anxiety or the other aspects of anxiety that can impact some of these. And we know that people who have especially social anxiety, it affects the perception of even minute facial architecture and facial expressions. So people with social anxiety interpret neutral faces as threatening or as negative, and things like that. So social anxiety certainly affects the way we perceive our social world and the cues in our world. And so that's not the only answer or the only way, but that does seem to be a piece to this, which is about perception and how we interpret our social world.
Yeah, that makes a whole lot of sense. We have 3 minutes left, so I want to give you all the opportunity to, if you had a message for everybody that's been experiencing this isolation, either about how to improve their health in the midst of isolation, or just some self-awareness about the impact of isolation and connectedness, what would that message be if you had a billboard for the world based on this topic? And we'll just go in order of the talk. So we'll start with Dr. Eidler.
Oh, I have social anxiety now. But I think I put my message on the last slide, which was keep in touch. So like, go home and call your parents or your brother or your sister and just say hello. I talked to my brother. I hadn't talked to him in a while, and I talked to him yesterday, and it was great. He was so funny. And so, renew those social ties, keep it on a clock, make sure that you check in with people, even if it's not for very long. Just to see how you're doing is a really good thing, to reach out and let somebody else know that you care about them, and they might not be expecting it, but you can brighten their day.
Dr. Sohn.
Yeah, I guess I can actually say the same message as Dr. Eidler, but in a slightly different way, is to appreciate the people in your life. Because I think one of the things that I think about on a daily basis is that time with people is limited. It can be a very long time, but it's limited. So, and it matters. And, do all the things that you would want to do and not put it off.
Dr. Mascaro.
Let's see, I think one thing that I try to remind myself, and I think is one of the most profound things that I see in the research world, is the just incredible power of just like lifting the gaze outward rather than to one's own navel and one's own thoughts. I think one of the fastest, most powerful ways to jolt oneself out of anxiety and suffering is just picking one's head up and sort of a quick helping behavior. I mean, it's sort of a wise selfishness. And there's a ton of research on how potent active helping and active volunteering, so not donating money, but actively doing things for others. It is such a wise selfishness, and it's the most, I think, potent bang for buck way to get out of one's own head is just look up and see who you can help. I think it's a really good way to get rid of anxiety in the short term and to improve well-being in the long term.
That's great. Put more good out into the world. So I think that we effectively answered the question, better together, as a yes. So with that, I want to thank all of you for your wonderful insights and for the work that you do. I think it's really important in this particular time. And keep an eye out for our next event. Like I said, it's going to be on isolation in the elderly. So that will be next. And I hope everybody has a wonderful evening. Thank you so much, everybody.